Hello friends, hope you are all doing well. Today our topic for discussion is outflow tract disorder of the female genital tract. This was a talk article published in 2019. So we will start with introduction. Congenital abnormalities of the genital tract are uncommon and the journal gynecologists will encounter these on rare occasion during their careers. As we all already know that we will rarely encounter these type of congenital abnormalities. So the congenital abnormalities of the genital tract can be isolated or in the case of an imperforate hymen are more complex involving the cervix, uterus and fallopian tube and thus potentially affecting fertility in some cases. Pregnancy may be impossible. Occasionally, congenital abnormalities of the genital tract may be associated with more complex syndrome, and the importance of these relationships need to be understood by dealing with complex problems. Some patients who have these anomalies will find it extremely difficult to cope physiologically and may need a multidisciplinary approach to manage their care. This is particularly pertinent as the majority of these patients are teenagers. So embryology, so you must have to a good understanding of the embryological development of the clinical representation in this condition. So the urogenital system develops from intermediate mesothelium of the peritoneal cavity and the endoderm of the urogenital sinus. The ovaries are derived from mesodermal epithelium lining of the posterior abdominal wall and the primordial germ cell formed by 4 weeks, subsequently migrating into developing ovary at 6 weeks and differentiate into oogonia. So this is a journal embryology. So if you know the embryology, then you will know about the different where is the congenital abnormality of the female genital tract. So both the male and female fetus initially have a Wolffian duct or paramesonephric duct that lies medially and paramesonephric duct that lies laterally. So the presence of Y chromosome lead to male sex determination, and in absence in the presence of 2X chromosome, the Wolffian duct regress due to lack of testosterone and the Mullerian duct persists due to absence of Mullerian inhibitory factor. As we have already known from embryology, that the ovaries usually from the mesothelium and then the some part of the uterus, ovaries, fallopian tube develop from paramesonephric duct. So in both male and female, paramesonephric duct and mesonephric duct both are formed. If there is no Mullerian inhibitory factor, then the Wolffian duct regress and the paramesonephric duct persist, and that lead to formation of uterine tube, ovaries and the cervix and upper part of the vagina. Okay. Then the development of the vagina had remained controversial, but the current understanding based on the work of Deuce suggests that sinovaginal bulb are the caudal end of the Wolffian duct, and therefore the development of the vagina arise by downward growth of a fusion of the lateral part of the Wolffian duct and Mullerian duct. This has been suggested following work show that mitotic figure are only present in lower end of the Wolffian duct. The solid vaginal plate extend caudally and eventually by 20 weeks of gestation cavitation has occurred, unifying the urogenital sinus, and that give rise to external genitalia with the uterus and cervix. It is therefore apparent that a number of uterine and vaginal anatomic abnormalities arise based upon either failure or development of normal structure or malfusion of the paramesonephric duct and vaginal plate. So in unicornuate uterus, it is likely that the failure of development of one of the Mullerian duct leads to its maldevelopment. So you have seen this picture. This is the ovary, this is the paramesonephric duct. Ovaries, paramesonephric duct, mesonephric duct, Wolffian duct that will regress, and the urogenital sinus. So the upper part of the vagina is formed from paramesonephric duct and the lower part from the urogenital sinus, and the rest of the female genital tract, like the rest of the female genital structures like labia majora, labia minora, so they all form from urogenital sinus. So they said that if there is only one in the unicornuate uterus, the failure of the development of Mullerian duct. So if there is a failure of the Mullerian duct, then there will be a single paramesonephric duct, Mullerian duct left. So it will lead to unicornuate uterus, this type of uterus, in which only you can divide into half. So this portion of the uterus can be found, and the rest will be absent in that. Then uterine duplication, uterine didelphys, biconjugate uterus, and the substrate uterus will all arise from varying degree of fusion of two Mullerian ducts. Failure of development of the cervix will cause cervical agenesis, and in case where both the mesonephric duct and the Wolffian duct fail to migrate at the caudal end, and this will lead to failure of the fusion with the vaginal plate and therefore absence of the vagina and failure of the development of the uterus. Interestingly, this condition is known as Mrkh. So, failure of development of the cervix, in which that the Wolffian duct failure to migrate at the caudal end, so it lead to failure of the fusion of the vaginal plate, and this lead to absence of the vagina. So lower part of the vagina will be formed, and the upper part, the panamesonephric duct, all will not be formed, so it lead to absent uterus. So this portion of the uterus is absent in Mrkh, rest the ovaries are present. Then many patients have small underdeveloped analogue on the lateral pelvic side wall, which presumably derive from Mullerian duct, and if the Wolffian duct have regressed and not fused with the Mullerian duct, then the development can be impossible. So the classification, there is no universal accepted classification of congenital abnormality of the genital tract. In 1988, the American Society produced a standard form of classification. This is from a lateral focus on vertical fusion defect. They have subsequently published current embryological classification in an attempt to link development with clinical presentation. So incidence. The incidence of congenital anomalies of the genital tract is difficult to determine, as many women with anomalies are not diagnosed if they are not symptomatic. Usually these patients have this type of septum, biconjugate uterus, so sometimes this incidental finding. But in some patients, if there is a uriconjugate uterus, so there is chance that there chance of miscarriage, and if those presented with recurrent miscarriages, one of the cause is that there will be some abnormality in the uterus. So you have to, if the patient present with recurrent uterus, so the first diagnosis will be your APLS. Then the next you will do a detailed pelvic ultrasound, 3D ultrasound, to exclude septate uterus, whether it's a biconjugate, uniconjugate, or didelphys uterus. Then the incidence is influenced by a steady group with normal reproductive outcome. The incidence ranges from 2 to 4%. These abnormalities are primary abnormalities of the uterine features, with septate uteri continues 90% of the cases, biconjugate आपके पास 5% है, and the didelphic uterus 5%. So most of the cases are 90%. Septate uteri. So in if there is a recurrent miscarriages, so you must have to exclude the septate uteri, because 90% of the cases are patient having septate uterus. So in septate uterus there is chance of miscarriages, recurrent miscarriages. So the first one development abnormality is Mrkh syndrome, uterovaginal agenesis. The uterus or upper part of the vagina is absent. The lower part is usually derived from the urogenital sinus. So the upper part is absent. The incidence of this condition is thought to be approximately 1 in 5,000 or 1 in 10,000 of the population. This type of station usually in both a single SBA came from this topic, and usually it came in exam regarding the counseling station, usually in OSCE. This is based on a single study from Finland and does not allow simical production for other population. Patients with Mrkh present in their teen age with primary amenorrhea in the presence of normal secondary sexual characteristic. So when the patient present with primary amenorrhea, normal secondary sexual characteristic, then you have to do her ultrasound to check whether uterus is present or not. If normal secondary sexual characteristic uterus absent, then your first diagnosis will be Mrkh. These patients have normal ovaries, and therefore puberty occur at the normal time and in the normal sequence. However, the absence of the uterus at the vagina means that there will be no menstruation. So approximately 40% of the patient with Mrkh will have associated renal abnormalities, and absent kidney is found in 12%, as already discussed in primary amenorrhea. So there are associated anomalies at a significant lower incidence, for example, spinal abnormalities, lower limb abnormalities, and 3% of the patient may have some degree of hearing loss. So you have to discuss this with the patient. Then after that, affected sibling will have documented as they have presence of Mrkh in discordant monozygotic twins. Of interest in that offspring to Mrkh patient who have conceived using surrogacy, there is yet to be used the child with Mrkh syndrome. The diagnosis is usually made clinically when examination reveals the presence of secondary sexual characteristic is associated with normal hormonal profile and genital examination. So imaging confirm the diagnosis, but laparoscopy is unnecessary. So you have to diagnose a normal ultrasound. So you can see that this is the hypoplasia aginus is vaginal or cervical. Then it is the unicornuate uterus, communicating and non-communicating, and the other, this is the diadelphys uterus, and this is the communicating and non-communicated, no cavity and no horn, maybe there with a horn or without a horn. And then this is the bicornuate uterus, heart-shaped uterus, complete, and this is a partial. And this one is septate uterus, complete septa up to the cervix, and this one is a partial. And arcuate uterus is like a slightly usually septate, partial or arcuate are almost same, slight differentiation in this. And DAC, diethylstilbestrol, drug related, like this type of uterus. So okay, then we have to continue with that. But in diadelphys uterus, there will be a double uterus. Okay, so you have to not confuse with a septate uterus. Then management of these patients require attention to two distinct. First, management of these congenital anomaly itself is ordered to allow to become sexually active, and the second is management of the psychological impact of this condition. It is now very well established without suitable psychological support. So in this you involve the multidisciplinary team involvement of psychologists, psychiatrists, and because they are usually psychologically give a it's a breaking bad news for the patient. So psychological counseling is very important, and usually for that for sexual activity you will tell them that she may have a sexual activity, but she cannot be pregnant, or she's not having menses, and if she want babies, then surrogacy is an option. So for that you will prescribe a certain treatment management option to maintain her sexual activity. We will prescribe vaginal dilators, and if it is not working, then we will do a surgical treatment. In surgical treatment, the technique involved, as you can see, the management involved the use of vaginal dilator as a treatment. First choice of treatment is vaginal dilator. And then there are many design of dilator available, and no particular design excel over other, but result achieved are significantly different when patients are psychologically prepared to undergo the treatment of the regime. So in a study shows that 90% have total satisfactory sexual experience with vaginal dilator. Some 25% complain that they have either poor lubrication or dyspareunia, and this does not interfere with their enjoyment of sexual intercourse. A surgical approach is rarely required, as there have been wider rate of surgical procedure, that the success rate is ranging from 80 to 90%. So in vaginal dilators, you may have to ask about what the success rate of vaginal dilator. So that is 95%, and surgical success rate is 80 to 90%. So in that we have to create a new vagina. So that procedure is called Vashiti procedure, and you have to search for that. McIndoe and Vashiti procedures, in which we have to create a new vagina through surgically. Then other outflow tract disorders of the vagina are other outflow tract disorder. The first one is imperforate hymen. The hymen is thin membrane that occur at the junction of sino-vaginal bulb with the urogenital sinus, and is usually perforated during fetal life. So this is for this failure of this perforation lead to membrane remaining intact as puberty begins. Menstrual flow collect behind the membrane, and the vagina begin to distend. This is often painless initially, and once the vagina becomes sufficiently distended, does lead to hematocolpus and cause discomfort. And it is sufficiently large, it may affect maturation or defecation, and may be palpable abdominally. So inspection, clear with inspection, and that lead to blue appearance of membrane that is bluish in presence, and darker blood transhuminating to the thin membrane. A differential diagnosis of transvaginal septum may be always be considered, but appearance will be totally different, with the septum being pink, although bulging become the septum is much thicker. So this treatment with crucial cruciate incision to relieve the obstruction, and remaining quadrant of the hydrum may be left in situ and may be excised. Following surgery, the hematocorpus will complete drain within 3 to 5 days, and usually no sequelae of this condition, however, in presenting early. So the other one thing is the transvaginal septum. The septum may occur anywhere along the length of the vagina, or they are classified as upper, mid, lower, and third, with the upper septum contain 46%, 30 to 40% in the mid vagina, and 50 to 20% in the lower. So this is one of the SBA in exam. It is usually, I think so, it's from Androsizer, that the septi occur at usually at which level more commonly. So more commonly you have to choose in upper part, usually in upper part, because the percentage is more in the upper part. So that is 46%. This is one of your SBA. The presenting symptom usually increasing cyclical abdominal pain and the absence of menstruation. It is uncommon for the diagnosis and can be missed for several months. Then ultrasound imaging will confirm the presence of hematocorpus, occasionally a small hematometra. If this have been sufficient time lapse between onset of menarche and the diagnosis, hematosulfics can also be occur. So the surgical management depend upon the excision of septal defect in the entirety and subsequent to end-to-end anastomosis of the upper and lower vagina. So you can see these are different level septum, so you have to cut it, and then you have to the end-to-end anastomosis of the upper and lower vagina. So a firm mold should be inserted to the site of anastomosis for a minimum of 10 days, and thereafter patient should be instructed the use of vaginal dilator for 2 to 3 months to ensure that stenosis does not occur, that the functional result will ensue. I've already told in previous primary amenorrhea lecture that you have to, after the procedure, you use a vaginal mold for minimum of 10 days or dilator for 2 to 3 months to prevent stenosis. Excellent results are normally obtained for lower and middle septal, and but for higher septal defect, the results are less encouraging, because it is higher and it is less encouraging. When the upper vaginal portion is short and there is a risk of damage to the bladder or rectum, and greater care has to be taken during the procedure, because it is at the upper level, it is more chance that the bladder or there is a rectum chances of injury, so you have to be very careful, and that's why there are less chances, successful chances with the upper portion. When these are higher septal defects are resected, a mold may be neat in situ for 3 to 6 months to obtain the better result. For if the middle and lower, we have to give vaginal dilator for 2 to 3 months, but if you are that one for upper part resected, then the molds should be used. There are special molds like a shape of a vagina, then they have to be retained for 3 to 6 months. So, however, difficulty with the patient in the age presentation often as young as 12 or to 13 years, when the cooperation with the use of either molds or dilator is difficult to ensure. This means that in some cases patient may retain some year later, and they have able to obtain menstrual drainage and use tampons. The ability to have a sexual intercourse may be difficult due to stenosis. So at this stage, a further procedure can be carried out in order to remove the stenotic area and attempt re-anastomosis, but this should only be done if the patient is capable of maintaining a regime of using vaginal dilator. So you have to tell the patient that she should have to use the vaginal dilator, because the stenosis will get again. Pregnancy success in patient with this type of disorder vary with the level of obstruction, reporting a pregnancy rate of 100% with the lower third of the obstruction, and 40% in middle third, and 20% in upper third. Because upper third, if there is a stenosis, maybe chances of stenosis occur, and they will if there is stenosis, maybe because the patient may complain of pain, and that there is less chance that the sperm can cross this area. Then after that, however, IVF is appropriate in this patient group if should be emphasized other than those with the lower third anastomosis. Delivery should be done by cesarean section. Patient with lower third problem can be allowed to have a vaginal delivery, and those having a lower third we can give a option of vaginal delivery. But if upper third septum, then vaginal delivery usually we will not advise. And ensuring the use of episiotomy to prevent lateral damage during head descent. Then the other thing is longitudinal vaginal septum. This is the transverse, and what is the longitudinal? Longitudinal fusion defect may be occur in the presence of two hemiuteri and two hemicervix. Embryologically, each cervix fused with the urogenital center to develop into hemivagina. We can see in the diagram. You can see this longitudinal septum. Sometimes this was the cervix, and sometimes they extend to lower down. So the septum that divide these may be partial or complete. So this one is a partial and this one is a complete. And patient usually present either difficulty with inserting tampons or discomfort using during intercourse, and they may not present at all until delivery when it is an incidental finding. Sometimes these of patient may present because they have a double uterus. As you can see in this type, this one is a partial, is may be present earlier, but in this case sometimes this is a full septum, so the pregnancy may be in the either uterus. I've seen one case in my training. So they have a double uterus, and the pregnancy in the one this I think so. I can't remember whether left or right, but this type of presentation is patient is having. So there may not be present at all until pregnancy when it is an incidental finding. Excision of the vaginal septum is usually advisable both to improve the chance of achieving a pregnancy on those who are trying to conceive, but also to avoid difficulty that may arise during childbirth. Excision is straightforward and can be carried out by sharp dissection, diathermy, or laser. If one of the hemivagina fail to complete canalize, a blind vaginal cavity result at the time of puberty when menstruation begin. Menses from the unobstructed vagina are found to flow normally, whereas obstructed heavy vagina accumulate menstrual fluid. This can create a confusing clinical situation which can lead to late diagnosis. However, eventually a palpable mass that lead the clinician to suspect the outflow tract disorder. Dysmenorrhea can be quite severe, and patients are sometimes admitted as emergencies. So the surgical management of these conditions involve careful excision of the vaginal septum and its entity, but care has to be taken because of their septum can be very thick, and it is ill advised to drain the hemivagina as a temporary means. This may result in ascending infection, septicemia, and life-threatening situation. So it is imperative, therefore, that these procedures are carried out by surgeon whose skill allow them to do surgery effectively, and the operation performed is curative. Usually, we also involve the plastic surgeons. The result of the surgery in these circumstances are excellent, and dyspareunia is really a problem. It is informed to the patient that their uterus diadelphys remain, and therefore obstetric complication need to be. We have to only remove the symptom, but the diadelphys uterus has to be remained. Then you can see that obstructed outflow anomaly, absent vagina, tertiary care, outflow tract referral center. If absent vagina, we have to refer to tertiary center, but they have different, they can categorize this: imperforate for secondary center, transverse vaginal tertiary septum, absent vagina, tertiary, and rudimentary horns, secondary or tertiary care center. Uterine anomalies for outflow perspective study. The only uterine anomaly that may cause problem is the presence of a rudimentary horn. In this circumstances, the caudal end of the Mullerian duct fail to fuse, and uricoordinate uterus with adjacent or attached uterine horn may result. So sometimes a patient may present with the amenorrhea, and those having pregnancy in the rudimentary horn. So you have to, because it's you cannot diagnose in ultrasound, but usually these type of diagnosis, when you are doing open laparotomy, then you have to open for ectopic pregnancy, then you suspect that, then you have seen that the ectopic pregnancy in the rudimentary horn. So what you can do, the horn is functional, and therefore at the time of onset of menses, the endometrium within the horn will be shed and therefore create a hematometra. Or sometimes they may present with the early and the young reproductive age when their menses started. with the retrograde menstruation and severe dysmenorrhea. In girls with dysmenorrhea that is unresolved through normal medication, the ultrasound should be performed to identify whether or not there is a rudimentary horn present or not. So sometimes the clinician may confuse it with endometriosis in young girls. So you have to do a detailed ultrasound to look for it is inconclusive, then you can do MRI, later on MRI, because the young age, to exclude uterine anomalies. In this girls, ultrasound scan should be performed to identify whether there is a rheumatoid heart present. When there are non-communicated, the horn need to be removed surgically and the uterus reconstructed. If it is that carried out meticulously, reproductive performance is the same as with a uniconvex uterus. Occasionally, these horn may be communicated. In those, the cases are usually asymptomatic. How, if diagnosed prior to pregnancy, they should be removed, because pregnancy and a communicating heart can lead to uterine rupture and fertility. As you can see this in picture, this one is the this type of, that's a cavity and having a unicornuate uterus and having a horn. Sometimes the horn may be not present, it is not worry, but if it is a communicating horn, have a proper endometrium and myometrium, so that's why the patient present with dysmenorrhea and hematometra. So that the choice of imaging to diagnose a congenital abnormality depend on the skill of the operator involved. In the vast majority of the cases, ultrasound scan is sufficient as long as ultrasonographer or radiologist is familiar with congenital abnormalities. In situation with anatomical structures in doubt, MRI can be carried out to delineate the congenital. So it is useful if MRI. For uterine anomalies, HSG or stereosonography can be outlined the uterine cavity and detect if the patient, if those having presented with infertility, and so you have to do hysterosalpingography. In young girls you will do MRIs, but those are reproductive age and want pregnancy, and if it is not happening, then we will proceed toward the hysterosalpingography. So management philosophy is that congenital malformation of the genital in teenage and adult women generate understanding anxiety with regard to sexuality, sexual function, and reproductive. The issues are complex psychologically as well as gynecologically, and evidence presented above illustrates superior outcome from patient treated in multidisciplinary holistic manner. Centers that try to manage these patients without an experienced team of health professionals are not giving their parents the best care, and those patients an ethical question about the appreciation of their approach. So this is a complete talk, and usually these type of station usually came in counseling, as a counseling station, and usually also in SBAs. So it is a very important topic, and so that's why I'll discuss in detail, and because in routinely you have to encounter such of patient with imperforate hymen transverse vaginal symptom, so you have a clear concept about that for both clinical and for knowledge purpose. So that's why I explained this talk, and it is a very beautiful talk. So if you have any queries, any question, you can comment on this lecture, or you can message on a WhatsApp group. Okay, thank you so much.